we have seen, today is our second session on pain, and we have a very eminent faculty today. Warm welcome to Dr. Mary Abraham. She is a neuroanesthesiologist and pain and palliative care physician. She is a visiting consultant in many hospitals in Delhi, and she has also achieved an excellent award, which is the Lifetime Achievement Award by Delhi Neurological Association for contribution to neurosciences in Delhi in the year February 2017. And her other interests are neuroanesthesia, pain and palliative care. And another salient point for all of us to know is that she's also authored a book titled Conquering Pain. Conquering pain is also an difficult task to achieve, and that she has done it through a book. Really big achievement, madam. The floor is for you to go ahead.
Thank you so much, Radha. And thank you, Shri Priya, for the warm introduction. And it's always a pleasure to take these classes for Pallium. And I'm honored to be one of the faculty of Pallium, where I can reach out to so many people all over India now. So without much ado, I would like to go ahead with my presentation. And I can share the screen, no?
Yes, ma'am. Access is already there.
Just 1 minute. Is the screen visible? The screen is not visible, no?
Not visible, ma'am.
No, not yet?
Not yet.
Let me just see how to go about it. Sometimes there's a little glitch in starting this, I'm sorry about that.
No worries, ma'am. We are ready to wait for a couple of minutes for a wonderful lecture.
No, I don't know. Always there's some glitch. I don't know. Let me see how to go about it. Okay. Let me start with my presentation. This is on pain management, and I'll be focusing, the broad outline will be on the basics of the WHO ladder, and I will focus on the step 1 and step 2 drugs of the WHO analgesic ladder, also for telling a bit about adjuvant drugs and the drugs that we use for neuropathic pain. Now, the WHO ladder was devised way back more than 30 years ago in 1986. And this was based on the recommendations of a group of international experts who wanted to know how to take the management of cancer pain further, because it was there were a lot of problems associated with management of cancer pain. And it was so successful that it was translated into 22 languages, and it has served as a catalyst for treating cancer pain worldwide. It's basically a stepwise approach to treating cancer pain depending on the severity or the intensity of pain. Now, prior to the ladder, that is prior to the 80s, people were dying in unnecessary pain for 2 reasons. First of all, there was a lot of drug regulations associated with the use of strong opioids. And the physicians were wary of prescribing it, and the patients were wary of taking it, fearing that they will get addicted to the drugs, and even the relatives were hesitant in giving strong opioids to their dear ones. So that was one problem. And there were a lot of strict rules regarding opioids. So much so that even people were hesitant in even storing it also, in the pharmacies and things like that. Then there was a lot of stigma associated with prescribing and taking opioids for the reasons I just mentioned. And when WHO advocated that strong opioids can be given as a step 3, it actually legitimized the use of opioids in cancer pain and also in the treatment of other kinds of pain. Let me start with a case scenario. This is a 35-year-old father of 2 young kids. He had a squamous cell carcinoma in the right upper lobe of the lung. The pain was deep-seated, gnawing in the right shoulder with burning and tingling in the right arm. He was unable to sleep. The NRS, the intensity was 4/10 out of during the day and 6/10 out of night. Now, before applying the ladder, we need to do a comprehensive assessment of pain. And for this, I think you are familiar with this mnemonic PQRSSTU. Okay, we all know about it. I think it must have been dealt with in the first talk. I will just focus on the second S, that is the severity of pain, because that is what we apply for the ladder. So it is very important to know the intensity or severity of pain, and that we come to know when we do a comprehensive assessment of pain. And another important thing is that we should know whether it is a nociceptive pain or a neuropathic pain, or is it a combination of the two, what is called mixed pain. So the WHO ladder is a 3-step ladder. The step 1 is for the treatment of mild pain when the NRS is less than 4 or less than 5. And what the drug that we give is a non-opioid analgesic with or without adjuvant. This non-opioid could be either paracetamol or a non-steroidal anti-inflammatory drug. Now, if the pain is not responding to the step 1 drugs, or if the pain's intensity itself is more than 5 to say 7, then you can go further up the ladder and add a weak opioid to the non-opioid and the adjuvant drug. And if it is not responding to this, or if the pain is very severe in the first place, then you can go on to the strong opioid, which is added to the non-opioid and the adjuvant drug if necessary. Now, using this ladder, up to 71 to 76% of cancer pain can get satisfactory relief of pain. Now, what are the salient features of the ladder? Please remember at least 3 of these, which is by mouth, by ladder, by clock. Okay, by mouth is the oral route is a standard route of administration of these drugs that we use for the ladder, even for the strong opioids. And that's a big disadvantage because it is very suitable for home care. It can be given by the attendant. It can be given by the nurse who's visiting them. And patient doesn't have to come to the hospital to get the strong opioids. So by mouth is a very big advantage. Even economically, it is much better. The second feature is that it's by the ladder. You start from step 1, and if the pain is severe, then you move up the ladder. Okay, so it is a stepwise approach to treating the pain. The third is it's given by the clock. That means it is not depending upon when the pain will come back, but it will depend upon the duration of action of the drug. So that can vary between various analgesics. For example, if you're giving morphine, the duration of action of immediate relief morphine is only 4 hours. That means you give the second dose after 4 hours of the previous dose. So the patient has to be told that you have to see the clock, and depending on that, if it's given at 6 in the morning, the next dose is at 10, then it's at 2, and so on and so forth. So by doing this, you can prevent the breakthrough pain that occurs, because if you wait for the pain to come back, that is a breakthrough pain. You don't want that happening. You want the patient to get good relief throughout the 24 hours, and that you can do by giving it by the clock. The next important feature is it is individualized to the patient. So the right dose of the drug is the one that relieves the pain. So it is not, it can vary from patient to patient. A patient with severe pain can get up to 300 mg morphine. Another patient can get only up to maybe around 60 milligram of morphine. But for both, the right dose is the one that is relief of pain. And also we have to tell them that in between the period of 4 hours, if there is a breakthrough pain, then what do you do? All that has to be specified. That is why you say you have to individualize it to that particular patient. The main thing is the pain should be relieved throughout the 24 hours. Another important feature is, if you notice, at every step of the ladder, an adjuvant drug can be added. And that is used to treat the various signs which are problems that are along with the pain. It could be a different kind of pain, like a bone pain or a bowel pain or a muscular pain. So, or it could be because of nausea, vomiting, or anxiety, depression. So various agents are there that can be added at every step of the ladder, and these are called the adjuvant drugs. And last but not the least is attention to detail is given when you're prescribing these drugs, taking into consideration the patient's age, whether it's a child or an elderly person, what is the body weight of the patient, what are the comorbidities, and what are the side effects. So many things have to be considered when you're giving the treatment to the patient. So the advantages of the WHO ladder is it is simple, it's very easy to understand. I explained it to you just now. It is a validated tool. That means it has been found to be effective when you apply it in the right way. And it's also very cost effective, because drugs like morphine, methadone, paracetamol are relatively inexpensive. It can be implemented across the world, even in underdeveloped countries, well suited for home care, because all these drugs are given by the mouth, and the relatives can be tutored how to give the medicine. It can also be given for other types of acute pain like fractures or post-operative pain, and it can also be given for chronic non-cancer pain as well. Now, certain modifications of the ladder have taken place. One is you can omit step 2 and go directly to step 3 if the pain is very severe, or you can add a 4th step to the ladder to treat crises of chronic pain that are not responding even to strong opioids. So this is one of the modifications in 2000, and this is for those 15-20% of patients who are not responding to the strong opioids. So you add a step 4. They could be in the form of a nerve block or an epidural or a patient-controlled analgesia pump. You can give a neurolytic block or spinal cord stimulators or an intrathecal pump using morphine. So many things can be added on, and these will be discussed in the next presentation on difficult pain. Now let's discuss step 1 drugs. Like I said, it is used to treat mild pain or even moderate pain, and these drugs are paracetamol, non-steroidal anti-inflammatory drugs, which can be combined with an adjuvant drug. So paracetamol is also called acetaminophen in the US. Now it has a predominantly central action. It inhibits the enzyme cyclooxygenase or COX in the central nervous system. It does not have an effect on the peripheral COX, unlike the NSAIDs, and so the side effects are much less. But it has a predominantly antipyretic and analgesic action. It does not have any significant anti-inflammatory action. So that is a drawback of paracetamol. So what are the doses? When you're giving it orally, it is safe in a dose of 12 to 15 mg per kg every 6 hours. You can go up to 3 grams a day. It should not exceed 4 grams. And a single dose should not exceed 1 gram. The normal dose that we give is around 650 mg every 6 hours. Nowadays, we have sustained release tablet of 1 gram, out of which 300 is released immediately and 700 is released over the next 12 hours. You can also give paracetamol as an infusion, 1 gram every 6 hours. And those in whom oral route is not feasible, for example, the case presentation I saw, when there's any oral cancer or a laryngeal cancer or a throat cancer, then you can give it even in the rectal route also. In pediatrics, it's very safe in a dose of 15 mg per kg every 6 hours. Toxicity usually occurs in doses of more than 90 mg per kg per day. What is the NNT of paracetamol? Now, NNT is the numbers needed to treat. It is the number of patients who are given this drug for one to have 50% pain relief over the next 6 hours compared to a control. So the lower the NNT, the more efficacious is the drug. The NNT of paracetamol is 5. What does that mean? That means for every 5 patients who are giving paracetamol, 1 gets good pain relief. So that is actually not a very efficacious analgesic as compared to drugs like ibuprofen and diclofenac, where the NNT is much lower. So the advantages of paracetamol: very good safety profile, undesirable effects are uncommon. It has no adverse effect on the gastric mucosa, can be given in patients with acid peptic disease, no adverse renal effects. It does not adversely affect the platelet function. It's tolerated by patients who are allergic or hypersensitive, especially to aspirin. And also it does not affect the plasma uric acid levels. But it has some drawbacks. The first drawback is it has to be given every 6 hours. It has no anti-inflammatory action, and it has a potential for hepatotoxicity. And that occurs when you give doses of more than 4 grams and those with impaired liver function. But even in patients with impaired liver function, you can give doses of up to 2 to 3 grams a day. And heavy alcoholics, you have to restrict the dose of paracetamol. Similarly, when those who have a low body weight, you can restrict it to about 2 grams. So what is the role of paracetamol in cancer pain? It is a mainstay drug of the WHO analgesic ladder because of its safety profile and because it has an opioid sparing effect. When you give paracetamol along with an opioid, you can actually decrease the amount of opioid that you're giving. And when you add it to NSAIDs, you can improve the NNT of NSAIDs. You can also add it to weak opioids like tramadol and even strong opioids like morphine. Now coming to the next step 1 drug, which is non-steroidal anti-inflammatory drugs. So they act by inhibiting the peripheral cyclooxygenase. So this is a very important step in the arachidonic acid cascade, which are producing the tissue and inflammatory prostaglandins secondary to a tissue injury. Now, prostaglandins are the important intermediaries in pain and inflammation, and they promote the pain, they amplify the pain by a process called peripheral sensitization. And this is specifically effective for nociceptive pain because that is where the tissue injury and inflammation is happening. So if you look at this slide, when there is a tissue damage, there is a release of a lot of tissue byproducts and the inflammatory mediators like bradykinin, prostaglandins, and serotonin. And they form what is called a sensitizing soup at the peripheral nerve ending. The peripheral nerve ending is a nociceptor for the pain. Okay, so that causes amplification of the pain signal. So if you look at it here, this is the first order neuron or the peripheral neuron. And this is a tissue where there's a tissue damage. And these are all the inflammatory mediators that are released. And they are the ones that are mediating pain and inflammation. Okay. And NSAIDs act at this level here. It acts by inhibiting the prostaglandins. So that is how it is acting by anti-inflammatory action. So if you look at it here, cyclooxygenase exists in 2 forms. One is COX-1, which is present in all normal tissues. It is part of the homeostatic functions of our body, and that is why it's called the constitutive or the housekeeping enzyme. So it is a beneficial enzyme which mediates the physiological responses like the protection of the stomach and the kidney and facilitates platelet aggregation. So that is necessary for the body. But when tissue injury happens, there is a release of phospholipids which produces arachidonic acid. And this is where you have the COX-2 that is released. And this is the one that is producing the prostaglandins and causing the inflammatory reaction. So we want a drug that is acting at COX-2 because it will have an anti-inflammatory action. Okay. We do not ideally want something that is blocking the COX-1 because that is a beneficial function. Okay. So there are 2 types of NSAIDs that are available. One is the non-selective NSAIDs that is interfering both with COX-1 and COX-2. And then we have the selective COX-2, which is interfering only with COX-2. If you look at the classification of the non-selective NSAIDs, you have aspirin, which are the salicylates, then you have ibuprofen, naproxen, ketoprofen, then we have the diclofenac, piroxicam, ketorolac, indomethacin. So these are all the non-selective NSAIDs. But technically, diclofenac can also be taken as a selective NSAIDs. I'll talk about that a little bit. So non-selective NSAIDs, like I mentioned, is inhibiting both COX-1 and COX-2. Because of the COX-1 inhibition, it will exert adverse effects because that is a beneficial enzyme. So it can cause the GI side effects, it can cause hypersensitivity, it can cause adverse renal effects. But by inhibiting the COX-2, it exerts its beneficial effect, which is the anti-inflammatory, analgesic, and the antipyretic effect. So non-selective NSAIDs is a double-edged sword with both adverse and beneficial. So coming to the non-selective NSAIDs, the drugs that are commonly used are ibuprofen, which is given orally in a dose of 400 mg every 6 hours. The NNT of ibuprofen is 2, which is very good as compared to paracetamol. Naproxen is another, which has an NNT of 2.5, 2.7. Now, the side effects of the non-selective NSAIDs are basically because of the COX-1 inhibition, like I told you. So it will have the adverse renal effects, the gastrointestinal effects, which can cause bleeding and ulceration and hypersensitivity reaction, which can be both respiratory and also in the skin or generalized laryngospasm also sometimes. Now coming to the selective COX-2 inhibitors. So they are not blocking COX-1, they're only blocking COX-2. And the examples are etoricoxib, given in a dose, a once a day dose of either 60, 90, or 120 mg, or celecoxib or diclofenac. It is functionally a COX-2 inhibitor. It has got a very good NNT of 2. That means for every 2 patients, 1 will get good relief of pain. Now, topical NSAIDs are also available. They produce the analgesic effect with less risk of systemic absorption and toxicity. And the examples are various creams with ibuprofen, diclofenac, piroxicam, and ketoprofen in it. Now, the question we need to ask is, are selective COX-2 inhibitors really safe as compared to the non-selective COX inhibitors? For the GIT, it is very safe as compared to the non-selective NSAID. But where the renal damage is concerned, it is as bad as non-selective NSAIDs. So it does not have any advantage where the renal damage is concerned. But on the other hand, it can be prothrombotic. And selective COX-2 inhibitors like rofecoxib, etc., were taken off the US market because of the increased incidence of thrombotic events which led to myocardial infarction and stroke. So in such cases, where there are patients are at risk of thrombotic events, either cerebrovascular or cardiovascular, the preferred NSAID would be ibuprofen or naproxen. If you look at the risk factors for the NSAIDs toxicity, where the GI is concerned, you have to be careful when we give it in elderly people and those with upper GI symptoms. For the renal toxicity, again, elderly people and those with dehydration, we should hydrate the patients. And those with a low creatinine clearance, you have to be very cautious and avoid it also. But those with risk factors for stroke and MI, like diabetes, hypertension, hyperlipidemia, or history of TIA, stroke, or angina, then it is preferable to avoid the COX-2 inhibitors because they can further cause problems because of the prothrombotic effect. Now, let us switch gears and come to the next step of the ladder, which is the step 2 drugs. Now, step 2 drugs are weak opioids, but they are not controlled drugs, unlike the strong opioids. And they are given for pain of moderate intensity, which is not controlled with step 1 drugs. Sometimes you don't need to go to step 2 and you can skip it and go directly to step 3. And I will be discussing 2 step 2 drugs, which is tramadol and tapentadol, because the other 2 are not available for current use. Now, tramadol is a centrally acting synthetic weak opioid. It has an opioid mode of action and a non-opioid mode of action. The opioid mode is by acting as an opioid receptor agonist. But because it is a weak opioid, there's less tendency for respiratory depression and addiction potential as compared to morphine. The non-opioid method of action is it acts on the descending inhibitory pathway of pain. And that is done by blocking the presynaptic reuptake of serotonin and norepinephrine. It is quite effective for neuropathic pain as compared to morphine, and it is a prodrug. A prodrug is one that is converted to active metabolites for its analgesic action by the enzyme cytochrome P450. Sometimes we very often use a combination of tramadol and paracetamol as a step 2 drug. It has a high oral bioavailability. Its plasma half-life is 6 hours. That means you have to give it every 6 hours. The oral dose is very potent. It's 1/10 as potent as morphine. And the equianalgesic dose of tramadol and morphine is 400 mg tramadol is equal to 40 mg of morphine. Basically divided by 10 and you'll come to know the equianalgesic dose in morphine. The dose is 50 to 100 mg every 4 to 6 hours with the maximum dose of 400 mg. Nowadays, sustained release formulations are available where you can, it is 50, 100 and 150 mg, which can be given twice a day. It has some side effects like nausea, vomiting, dry mouth, constipation, dizziness, sedation. And also there's a risk of seizures when the total dose is exceeding 400 mg or when you're given with drugs that lower the seizure threshold like TCAs or SSRIs, or when you give it as a rapid IV injection. The other step 2 drug is tapentadol. It is a newer step 2 drug, presumably a weak opioid, but opioid binding studies have shown that it's actually quite a strong opioid. It also has a dual method of action, just like tramadol, with an opioid method of action and a non-opioid method, just like tramadol. It is not a prodrug, unlike tramadol. That means it has no active metabolites. But its side effect is better than tramadol, and the risk of seizures is less, but you should avoid it in severe renal and hepatic dysfunction. The dose is similar to tramadol, and the maximum dose should not exceed 600 mg. And you can see that 50 mg tapentadol orally is equivalent to 15 mg morphine. So the ratio is 3:1. So the various analgesic combinations we can use are never use 2 drugs of the same category. Like you don't combine a COX-1 and a COX-2 drug, or you don't combine a weak opioid with a strong opioid. But you can come, these are the combinations that are favorable, which can actually potentiate the action of analgesia, at the same time decrease the side effects. Now coming to the next section on neuropathic pain. I've discussed step 1 and step 2, and now I will be discussing the adjuvant drugs. Now, it is important to know that cancer pain is not just nociceptive. You can have various other elements, like 40% of cancer patients can have neuropathic pain. There could be bone pain, there could be bowel obstruction pain, there could be other symptoms, and there could be muscle spasm, and that is where the role of adjuvant drugs are coming into focus. So adjuvant drugs, the primary indication is not pain, but it has analgesic properties, and that is why it is called co-analgesics. So this is a classification of the adjuvant drugs. You have multipurpose drugs, adjuvant drugs, which are the antidepressants, corticosteroids, or alpha-2 agonists that can be given for a variety of pains. Or you have ones that are for specific pains, like neuropathic pain, or bone pain, or bowel obstruction pain, or musculoskeletal pain. So they are also adjuvant drugs. Now coming to a little bit about what is nociceptive and neuropathic. Now, nociceptive pain is occurring at the site of tissue injury, which is the peripheral nerve ending. Anything beyond the nociceptor, which is the peripheral neuron or the first order neuron, or the spinal cord, or the ascending pathways up to the brain, this whole thing comes under neuropathic pain. So a lesion in this area will lead to neuropathic pain, and that is a definition given by the IASP 2018. But you can also have a mixed pain of both nociceptive and neuropathic. So why does neuropathic pain occur? It can be either due to direct invasion or compression of the nerve because of the tumor or the cancer, or it could be because of the treatment of cancer as well. For example, chemotherapy-induced peripheral neuropathy, very common, or radiation-induced peripheral neuropathy, or it could be due to the surgical excision when an injury of the nerve has occurred. And sometimes it even happens in cancer survivors where it can persist for months to years because of the permanent nerve damage caused by the chemotherapy. So the first line of treatment of neuropathic pain is the anticonvulsant drugs. Now, why are anticonvulsants used for neuropathic pain? Because there's a shared pathophysiology between epilepsy and pain. In both, there is neuronal hyperexcitability. And these drugs actually dampen the neuronal excitability. And the most commonly used anticonvulsants are gabapentin, pregabalin, or sodium valproate. How do these act? They act by binding the voltage-gated calcium channels. Okay, and so there is a decreased influx of the calcium into the presynaptic neuron. And because of that, there is less release of these excitatory neurotransmitters. And then consequently, a less excitation in the postsynaptic neuron. But besides a calcium block, it can also act on the sodium channels, and also it has a GABA, enhances a GABA-mediated synaptic inhibition as well. But this is the main method of action of these gabapentinoids. So what are the gabapentinoids? One is gabapentin and pregabalin. They have a very good effect for neuropathic pain, well tolerated. And the side effects we should keep in mind are somnolence, dizziness, ataxia, fatigue, impaired concentration, etc. So if you look at both drugs, the gabapentin, the oral bioavailability is less predictable as compared to pregabalin, and it is less expensive as compared to pregabalin. And titration is very simple with pregabalin. For this, you have to do it in multiple steps. Now, certain drugs are available topically for the use of neuropathic pain. They are topical gabapentin is now available, and also topical capsaicin, 8%. Okay, it's a pungent component of chili pepper, but it's not freely available in India. And a single patch in the painful area for 30 to 60 minutes can produce pain relief for 12 weeks. Now, coming to the antidepressant drugs. This is also a first-line treatment for neuropathic pain along with the anticonvulsant drugs. The onset of analgesic action can take 1 week, but the analgesic effect occurs is not dependent on their antidepressant effect. It can occur earlier and at lower doses. And it is very particularly useful in cancer pain because these patients are frequently having depression and anxiety and insomnia. How do they act? They act by activating the descending inhibitory pathway of pain by preventing the reuptake of norepinephrine and serotonin. So what are the antidepressants in clinical use? This is a classification. The commonly used ones are the ones mentioned above. That is the tricyclic antidepressants, the selective serotonin receptor inhibitor, and serotonin norepinephrine receptor inhibitor. So SSRI, SNRI. But nowadays, people are using drugs like mirtazapine, which is a very specialized serotonin inhibitor, and also some atypical antipsychotics like quetiapine, risperidone, and olanzapine. They are much less frequently used. These are the ones that are commonly used. So the commonly used ones, like I mentioned, are the TCA, in which you have the tertiary amines like amitriptyline and the secondary amines like nortriptyline. Serotonin SNRI are duloxetine or venlafaxine, and the SSRI are acetalopram, citalopram, paroxetine. Okay. But the SSRI have less analgesic effect, and they are more used for anxiety and depression. So you look at the analgesic effect, the TCA has got more analgesic effect as compared to the SNRI as compared to the SSRI. But the side effect profile of TCA is more than for SNRI and SSRI. So what are the side effects? The CNS side effects of TCA are somnolence, drowsiness, mental clouding, and suicidal tendency. And the anticholinergic effect of TCA are because of the antimuscarinic effect. So it can cause dry mouth, it can cause acute angle glaucoma, blurred vision, tachycardia, urinary retention, constipation, orthostatic hypotension. So the contraindications for use of TCA are severe cardiac conduction defects or arrhythmias, severe prostatic hypertrophy, or narrow angle glaucoma. If you look at the SNRI, the side effects are the same: somnolence, dizziness, and with a special suicidal risk as well. And the contraindications are for venlafaxine, you should avoid it in patients with hepatic and renal insufficiency and high BP. For duloxetine, avoid it in patients with hepatic insufficiency. So if you look at the dose administration, for amitriptyline, you can start with a dose of 10 mg, and every 3 to 5 days, you can step it up to 50 to 100 mg per day. Nortriptyline, similarly, start off with 10 mg, duloxetine, 30 mg, and you can go up to 60 mg per day, or even twice a day, 30 mg, or venlafaxine at 37.5 mg, and then you can step it up. For gabapentin, you can start with doses of 100 mg and 300 mg, depending upon the age and body weight, etc. Pregabalin, you can start at 75 mg. But just remember, all these doses have to be adjusted for the medically ill and for patients with renal and hepatic dysfunction. In a recent study of the effect of duloxetine in patients with chemotherapy-induced peripheral neuropathy, or CIPN, it was found that those receiving duloxetine from weeks 1 to 5 had larger decrease in pain as compared to placebo-treated patients. And the 2020 guidelines suggest duloxetine for the initial treatment of painful CIPN for 5 weeks. The other drugs in neuropathic pain are ketamine. It acts by blocking the NMDA receptor that is situated in the dorsal horn of the spinal cord. And it is particularly useful when the drugs, they are not responding to the antidepressants and anticonvulsants. It has got side effects like dysphoria, hallucinations, nausea, vomiting. You can prevent it by adding haloperidol or a benzodiazepine before giving the drug. It can be given through a variety of routes: IV, IM, subcutaneous, oral, sublingual, intranasal, rectal, topical, intraarticular, epidural, even intrathecal. Its bioavailability after IM injection is very high, it is 90% at 5 minutes. So ketamine is actually an anesthetic drug, but in sub-anesthetic doses, it acts as an analgesic, particularly for neuropathic pain. So the oral dose is around 10 to 25 mg per day, and TDS. And for subcutaneous and IV, you can go up to 100, 50, 100, or 200 mg per day. For difficult pain, you can give what is called a burst ketamine infusion. I'll talk about that in my next. Now, the other drug that are given for neuropathic pain that is not responding to anticonvulsant and antidepressants are the local anesthetics. They act by decreasing neuronal excitability at the level of the sodium channels. And it is particularly useful for severe intractable crescendo kind of neuropathic pain. It can be given as an IV local anesthetic infusion. You give a dose of 5 mg per kg, add it in 500 ml of normal saline, and give it over 1 hour with cardiac monitoring. So it is a daycare procedure. But you can also give it topically. 5% lidocaine patches are now available in India. You can apply up to 3 patches a day. But when you apply it for 12 hours, for the next 12 hours, you have to remove the patch. The other drugs that are used, the other topical agents, like I mentioned, you can use topical capsaicin and also topical gabapentin. So this is a neuropathic pain ladder. The first line treatment is amitriptyline, pregabalin or gabapentin, duloxetine, and lidocaine patch. And the second line of treatment are opioids like methadone or tramadol or tapentadol. And third line is drugs like ketamine and capsaicin patch. Now, corticosteroids. This is a multi-purpose analgesic or a multi-purpose adjuvant drug, because not only neuropathic pain, it can be given for bone pain, it can be given for intracranial tumors and metastasis, it can be given for bowel obstruction and also for spinal metastasis. So if you look at the various steroids that are available, dexamethasone has a very predominant anti-inflammatory effect. It is 25 to 50 times more potent as compared to hydrocortisone. It has a long half-life, 36 to 54 hours, so which means only a once-a-day dose is required. So this is the advantage by which dexamethasone is a preferred drug for cancer. So I said it has also got less mineralocorticoid effects, but these steroids should be given in the morning because it can tend to cause insomnia. And particularly for those with less life expectancy, it can provide short-term relief of pain, which may not be very long lasting. So when you want to give dexamethasone for brain mets, you can give in a dose of 4 to 8 mg for 24 hours, once a day. For severe mets, you can give up to 16 mg. For bowel obstruction, malignant bowel obstruction, you can give up to 16 mg. And these can also be given as an appetite stimulant also in cancer because of the mood elevation. The other adjuvant drug, which is actually a multi-purpose drug, are the GABA receptor agonists. GABA is basically an inhibitory neurotransmitter, and these drugs potentiate the inhibitory action of GABA. So you have two kinds of GABA agonists. One is GABA A, which are the benzodiazepine, and out of that only clonazepam is used for neuropathic pain. And then you have a GABA B receptor agonist, which is baclofen. So clonazepam has been used for neuropathic pain in a dose of 0.5 mg. 0.5 mg or 500 mics can be given orally. It's also been used for terminal sedation as well. Baclofen acts by potentiating GABA B. So besides neuropathic pain, it can also be given for musculoskeletal spasms, for hiccups, for spasticity, etc. And you start with 5 mg and you can keep going up to 20 mg TDS.
Ma'am, can you please repeat about clonazepam again?
Okay, clonazepam is a GABA A agonist. Okay, it is a benzodiazepine. But out of the benzodiazepine, only clonazepam is found to be effective for neuropathic pain. So you can give in a dose of 0.5 milligrams every day.
Thank you, ma'am.
Okay. And it has also been used as an infusion for terminal sedation, up to 2 to 8 mg per 24 hours.
Thank you, ma'am.
Now coming to bone pain. Now, bone pain is a very important cause for causing agonizing pain in cancer. It affects the quality of life of the individual. And this is because of the metastatic bone disease causing skeletal related events, or it could be a fracture, it could be a tumor in the bone, which stretches the periosteum, etc. So all these can cause bone pain. So there are various drugs, the agents that can be given for bone pain. They include steroids or non-steroidal anti-inflammatory drugs, calcitonin, but the latest reviews show that there's no significant improvement in the quality of life. The other drugs that are used for bone pain, which is commonly used, are the bisphosphonates and denosumab. They act by inhibiting the osteoclast-mediated bone resorption and thus reducing the skeletal-related events. And also you have palliative radiation. So bisphosphonates are very important by blocking the osteoclastic events. The one that is commonly used is zoledronic acid. So how do you give it? You give it as an intravenous dose of 4 mg in 100 ml of normal saline over 15 minutes. And you have to give it every month for a year. It has got side effects. One is it can cause pyrexia, it can cause renal dysfunction, and it has got a very bad complication which causes osteonecrosis of the jaw because of the bone resorption. So patients with creatinine, with renal dysfunction, you have to reduce a dose based on the creatinine clearance. Denosumab is the other drug that can be given. It's a human monoclonal antibody, but as compared to zoledronic, it's more expensive. It can be given subcutaneous. That's an advantage, but with less risk of renal toxicity. But it has more risk of hypocalcemia, but it is very superior as compared to zoledronic acid to delay the skeletal related events with a better median survival rate. But if you look at the cost of the drugs in India, denosumab for a month will cost 32,000 because it has to be given twice a month. And zoledronic acid will come to just 900 rupees. So there's a big cost difference. Cost that's similar. Palliative radiation for bone mets. You can use various bone targeting nucleotides like strontium and samarium. And so they can cause good relief of pain as well, particularly when it is focal lesions in the bone. For malignant bowel obstruction, I'll just take a couple of minutes more. I'm sorry, I'm exceeding the time. Malignant bowel obstruction, you can use steroids that decreases edema in the bowel, or you can use a somatostatin analog like octreotide. This is a synthetic hormone that decreases the intraluminal secretions and the peristaltic movements. Or you can use an anticholinergic drug like hyoscine butyl bromide or glycopyramide. Sometimes you can combine all the agents. The other adjuvant drugs are skeletal muscle relaxants or neuroleptic drugs, particularly when there's hallucinations and all. You can use the antipsychotics like olanzapine, quetiapine, and risperidone, or you may have to use sedatives or anxiolytics or antibiotics, etc. So in this chart, you can see where the various drugs that adjuvant drugs are acting at different parts of the pain pathway. This is a pain pathway to the brain. You can see that muscle relaxants act at the muscle level. The nociceptor acts, the local anesthetic and NSAIDs are acting at this level, like I showed earlier. In the peripheral neuron, it's various drugs like these are acting. And at the dorsal horn, the drugs that are acting are the anticonvulsants, antidepressants, opioids, and the NMDA agonists. And the descending modulation of pain, predominantly the step 2 drugs like tramadol, tapentadol, or the TCA or the SNRI. Yeah. Now, coming back to our case scenario, I talked about this patient, right? So how do we treat this man? Now we have to look at the intensity of pain. In this case, it was mild to moderate pain. The type of pain, it had both a nociceptive and a neuropathic component. The temporal nature of pain, it was worse at night. And if you unveil the meaning of pain, there could have been a functional, emotional, social, and financial aspect because of his young kids and possible concerns where the financial and social aspects are concerned. So how do we start with? You could start with a WHO step 1 drug, give a combination of paracetamol and NSAIDs, but because the pain was more at night, you can either add a sustained release paracetamol like 1000 mg, or you can add a diclofenac SR at night so that the night is also covered. Then because of the neuropathic pain, you may have to add an anticonvulsant and antidepressant, which could also work for better sleep at night. You may have to give a sedative also, and you need to look at the psychosocial support that you can offer this gentleman. To summarize, the WHO analgesic ladder is a sheet anchor for cancer pain management. It can also be used for non-cancer pain. Very simple, easy to implement. It's used worldwide, and it has legitimized the use of opioids, like strong opioids in cancer and non-cancer pain.
Thank you very much, madam. Really, and exactly what they need to know. Okay, so well said. And especially your learning point slide is what everyone has to take. Okay, it has got everything in it. Basically, you have to diagnose or know in entirety about the pain and then deal with it. So as you said, step 1 medication plus the neuropathic element, because if he gets good sleep, that is rejuvenation for him.
And it also decreases the sleep pain threshold.
Exactly. So
the person gets good night's sleep, pain is much less than
next day. Management. So I'm gives him so much of confidence oh, I have been able to sleep, my pain is low. That self-subjective experience does more wonders than anything else. So exactly, like as I said once again, that learning point slide is that what you have to all of you take home. Important. So entirety, everything. So if anyone has a burning question straight away, you can ask or type in the chat, or we can go to the case and then come back for question discussion time in together, because the case is also going to deal with something similar. Does anyone have something that they would like to ask Madam straight away? There's something in the chat box, Madam. I will just see and tell for you. Bisphosphonate drugs can be given safely if patients if there's no kidney issue, can that be given straight away?
Yes, it can.
Yes, it can.
Clearance is important. So if the creatinine clearance is normal, then it can be given straight away. But if the creatinine clearance is low, there's a way in which you can reduce the drugs.
Titration. Basically, need to be titrated according to the creatinine clearance level. Okay, so that answers that question. There's one more. Let me read it for you. Among bisphosphonates, is only zoledronic acid useful, or are there other drugs that have shown to be useful?
The earlier pamidronic acid was being given, but now I think zoledronic is being widely used. That's what.
Yes, ma'am. Yes, madam. That's what, like, even as when I was working in Cancer Institute, zoledronic acid is what is Zomato, I think is the trade name or something. That is what is used a lot. I mean, as madam explained very clearly, the cost effectiveness plays a very, very big role. Okay. Yes. The socioeconomic status, and someone should be able to get that regularly rather than getting one dose and not getting anything. Whereas if they get it if they get it on a monthly basis, better benefit. Okay, in that case, shall we go on to case presentation?
I think there's one more question in the chat.
Yes, I'm reading that, madam. Which one will be better for neuropathic pain? Alprazolam versus escitalopram, also with the anxiety.
See, I told you among the benzodiazepines, it's only clonazepam that has been shown to be effective in neuropathic pain. So it is not alprazolam. Alprazolam is purely anti-anxiety. So, but escitalopram is a selective serotonin receptor inhibitor. It can deal with anxiety, but not so effective for pain as compared to the SNRI or the TCA. But you can add it also. Along with your SNRI, you can give SSRI also, if you feel the anxiety component is more. So we are very often combining, even with TCA, I have used escitalopram as well.
See, that's what, as madam said, no, first you stick to the 1 and 2, then go to the next. So if you follow like this step, WHO ladder, even with adjuvants, if everyone follows, because that is what is given as guidelines everywhere. Like you have the TCAs, you stick to that always. And TCA or anticonvulsant will be better to be as first step. Just
how like about amitriptyline or nortriptyline 10 mg? That will be better, TCAs. No, ma'am? That will be better than yes. First we need to start with that, right? Then
yes, that is step
SNRI, sir. Yeah.
So that is step 1. Yeah. So better to use that first and then move forward. Just by the way, madam, I've also done chronic pain and as I've been a pain physician for quite a long time. So for that is a prescribed guideline also is that to use that, as madam mentioned, the step ladder type with the adjuvants also will be safe and best. And hope you would also agree with that.
I also want to say that you can add Alprax also if the patient is very anxious. Because very often I'm giving another benzodiazepine called lorazepam also. Okay, so you can add it. If you find the patient is not getting sleep despite the drugs that you're giving like anticonvulsant and TCA, you can add a lorazepam or alprazolam, no harm.
And what is your experience with duloxetine?
Duloxetine, I told you, is also very good for neuropathic pain. And it's particularly for the chemotherapy-induced neuropathic pain. It has been particularly found to be useful for that kind of pain. But you can use, see, the only thing is, if you look at it, I think amitriptyline is more cost effective. So you have to look at the patient profile also. If the patient can afford duloxetine, you can give duloxetine. But as a routine, I start off with either amitriptyline or nortriptyline. But if there is a chemotherapy-induced peripheral neuropathy, then duloxetine is supposed to be quite effective.
Ma'am, I have one more doubt, ma'am. Like initially when we start with morphine, for severe pain, is it okay to start both morphine and this amitriptyline? Like, will it cause excessive sedation, or should we start it in a stepwise way?
See, if the patient has got an element of neuropathic pain, you can add the amitriptyline to morphine, no problem.
Excessive sedation will not be an issue?
No. When you're starting morphine in the proper way, it will not be an issue. And you can add, because morphine doesn't take care, although recent evidence is saying that morphine can also take care of neuropathic pain. But amitriptyline is a first-line drug for neuropathy.
Yes, ma'am. Okay. Thank you, ma'am.
You can add.
Thank you.
Can be added safely without, like you're adding. See, generally, one more thing we say, the dose that we're using, that is the 10 milligram, is a very, very small dose. So you can be confident in adding, and it takes few days. You have to tell them, you have to give 1 week to 2 weeks for it to start working. So a little bit of patience and perseverance in continuing the medication will give benefit. And the dose given, that 10 milligram, is very low dose. It's a safe dose. So add that, and combined additive effect will give more benefit.
Thank you, ma'am.
Madam, can we go ahead with the case presentation and come back to the questions, or I'll just check one more thing is there in the chat box.
They're asking whether you can come down the ladder also.
Yes. That
can, because
exactly.
there's so many people who are cancer survivors. That means the cancer has come under control. So as the cancer comes under control, the pain also will come under control. So you can come down the ladder easily. Yes. As you're going up, escalation, de-escalation can be done.
Assess, reassess. According to your assessment and reassessment,
comprehensive pain assessment has to be done at every stage. The comprehensive pain assessment.
Exactly. Okay, let's go ahead with the case presentation and come back.
Dr. Hemaja.
Good morning, ma'am. I'm Dr. Hemaja, pain physician and anesthesiologist by profession. So today I'm presenting a case. It's a patient, 24-year-old, and he presented with a ulceroproliferative growth over the left buccal mucosa. It was since 2 months, and he had a swelling in the left neck, lateral neck, which was also 2 months, and he also presented with a burning pain as well as discharge. He presented with a burning pain with no discharge, no discharge from the ulcerative growth. It started off as a small nodule which gradually increased in size. Later it ulcerated, and the pain also started along with the growth. Then the ulcer reached up to 5 into 5 centimeters. Then the patient noticed a swelling in the left neck, which was small, pin size, which gradually increased to a beetle nut size, bottom size. That's what he told me. And the patient also is a known case of epilepsy. He had a history of epilepsy, and he's on anti-epileptics, but he discontinued due to during the COVID time. What he mentioned was the financial issues, and the last episode was also in 2020. And he's a known case of alcoholism from the age of 15 years, and a gutka chewer, a tobacco chewer, and a BD smoker, and he smokes 1 pack of BDs every single day. And this is a patient. He presented with a mouth opening of more than 2 fingers, and there was an involvement of level 1B, 5, and level 2 nodes. And the patient presented with a pain. According to the numerical pain scores, it's around 8, with pain was strong pain. And the treatment is, before the treatment, I'll go to the investigations. The investigations, biopsy was done. Biopsy shows a left buccal mucosa squamous cell carcinoma, which was moderately differentiated, grade 2. And the CT neck was done, and it shows CT was done along with the CT and the CT neck. Heterogeneous enhancing soft tissue density mass lesion involving the left buccal mucosa and the extension and the involvement of the nodes. And the treatment which was suggested was a commando operation. He underwent the commando operation, that is combined mandibulectomy and the neck dissection operation. And according to him, the psychosocial aspects of for this patient is, first, the patient is an younger age patient, is just 24-year-old with a family and 2 young children, 1 infant, 1 toddler. And his problem is about a disfigurement, financial loss, the treatment cost. Because he has a metastatic lesion, he has to undergo radiotherapy after the surgery, and he is concerned about the fear of dying, because he already has a metastatic, and he is not sure about that, whether there is any other metastasis in other places. And there is a concern for the family because he has 2 young children. Then he has the loss of control, he has anger issues, and he has guilt because he was taking tobacco and gutka chewers. No one suggested him that he should not, and he's in utter shock, disbelief and all. Now he's on treatment. First, we suggested him paracetamol 650 mg. Then since the pain was not subsiding, then we have given him diclofenac 50 mg and the paracetamol 500 mg. The second line of drug we gave was stepentalol 50 mg, and along with that we gave him antidepressants like amitriptyline, and we were giving him gabapentin, pregabalin, because he has an inferior alveolar nerve involvement. He had a neuropathic pain. Then when in case of some breakthrough that pains, we used to give him morphine for severe pain. And morphine, we used to give him either 10 mg TID or 20 mg TID, max to 30 mg TID. And further, in case of severe pain, we have suggested him ganglion block, trigeminal neural or trigeminal block, or cryoablation or RF ablations in future. And his main concerns were the financial loss, and then his hospital stay, because it was a long stay, because he has to undergo radiotherapy, and his disfigurement, and social acceptance. Coming to the summary, is a 24-year-old young male patient with a left squamous cell carcinoma with distant metastasis and a patient of epilepsy. He was admitted for a surgical removal of the lesion, that is a combined mandibulectomy and neck dissection. So the discussion points for this patient is severe disfigurement leading to denial and loss of work, and fear of death, guilt, severe pain leading to continuous, he was taking continuous medications. That itself, he was in severe depression. Then what I felt was he needs severe counseling and financial aid support from the family. Thank you, ma'am.
Thank you, Doctor, for the excellent presentation, an appropriate one, having most of the issues, and he's been on medications too. So we will keep the case open for everyone's discussion. People could type or unmute yourself and ask, raise your hand or unmute yourself and ask any particular issues you want to say, and we could just discuss or take the discussion points itself could be taken one at a time and seen what exactly would be the response. We'll wait for people's ideas and input and then take it from there.
There's a question in the chat box that tramadol has addiction potential. Now, because it's a opioid, the advantage is less depression and less addiction potential. Okay? That is one of the advantages over morphine. I just want to know, Hemaja, it was a very good presentation. You did it very well. I just want to know whether with the drugs that you were giving, what did the NRS score come to? From 8 to 9, did it come down significantly or was it the same?
It has come down, ma'am. Before it was 8, and after the treatment, we were giving the last was morphine. With morphine, he has come down to 3, ma'am. So that too, morphine was 30 mg TID. With that, the pain has subsided, ma'am.
But then now he's going for an operation, right?
He
So
underwent surgery, ma'am. Mandibulectomy was done, and he's undergoing radiotherapy as of now, ma'am.
Okay. So now the pain is controlled at 3?
Now the pain is at 3, ma'am.
He's able to take orally?
No, ma'am.
Then how are you giving the morphine? Through Riles tube?
He is through Riles tube, and for some time he was given parenteral nutrition, ma'am, because first thing, he himself was in denial and he is not able to accept anything because there was a leakage, that dysphagia, the pain and all. So after that, he slowly started taking with counseling, family support and all. He used to take with a spoon, and then now he started, ma'am.
Okay.
Liquids and semi-solid food.
So pain has come under control, but now you need to the other aspects of his pain. And that's it, now.
Yes.
Exactly, madam. Madam, you're muted yourself, madam. You may have to unmute yourself.
Muted. I'm not muted.
Now we can hear. Now we can hear.
See, pain is a total pain management, right? We are looking at the physical, emotional, social, and spiritual aspects of pain. So in this, we have more or less taken care of the physical aspect. So now you need to look at the emotional aspects. We need to look at the social aspects and also counsel him about his guilt and things like that, you know. Okay, so, right, am I right?
Exactly, madam. As you said, no, when the score has come from 8 to 3, it is well understood that the pain relief has been there. But see, with him, specific points, why is that we are facing all this? His age, see, 24-year-old. So that is one of the important thing why he's feeling, generally that age group, he may feel that he's young to go through all this. So he will need one-to-one counseling, family counseling, everything has to be done for him. So psychological element of it, psychological and emotional element has to be done. And then the guilt and all those things, no? See, at that point, everyone is told that tobacco chewing is dangerous, injurious to health, is put on every cigarette box, but no one accepts that. So that could be achieved only by sessions of counseling. One counseling will not achieve anything. So here what is needed is few sessions of individual counseling, family counseling, and then next we have to look at support for the family. We have to get if he's having any family issues, if that could be dealt. So more of a total pain management is what we are looking at. And from the, as you have mentioned that the pain score has come down. So next thing is that we have to make sure that he continues the medication. So that also is important, encouraging him to continue the medications regularly so that he will keep the pain under control. And then assuring him that if whatever support, the counseling support could be provided, we could give that and then take it from there. And then there's something else in the chat also. Let me have. What the question is, if someone has tried all pain reliever, what next? What do you mean by tried all pain reliever? That question, no, like mostly you have to follow the step ladder and then, or madam wants to say anything, madam?
No, I think that we have come to the step 3. The patient has got good relief. So why should we go do anything?
Exactly. No, there was a question in the box, chat box, madam, if they've tried
I know that.
all.
I saw that. Tried all pain relievers. What next? I said, right now we have achieved control of the physical pain.
Exactly.
And we can go up, I mean, further up the dose also. 20 mg TID. If it is not, then you can keep going up also. No,
exactly. Frequency can be.
Frequency can increase because TID may not be the
4 hourly.
Make
it 4 hourly.
Exactly.
So like frequency, those are the things have to.
By the clock, every 4 hours.
Exactly. Very, very important, madam. That slide is by the clock. By the clock is because it gives continuous sustained blood level. That is important for pharmacology. So only when the underlying sustained blood level of the analgesic is there, better benefit we are going to have. So by the clock.
Excuse me, ma'am.
Go ahead.
Yeah, excuse me, ma'am. No, in the discussion, it's put severe pain leading to continuous medication. That's the reason I asked that question. But it has been answered. The pain has been relieved. Okay.
So there's a question in the chat box. Is social and financial aspects contribute to physical pain? Okay. So that is very, very correct. It can cause social and financial and psychological aspects can cause the patient to feel more pain. Okay. If even if the actual physical pain has come down, but if he has so much concerns about his family and about his grief and all that, they can cause pain as such, because there's what is called a gate control pathway of pain. I don't know if you all are familiar with the gate control pathway of pain. That is, there is a gate at the spinal cord which opens or closes. If it opens, all the pain impulses go up to the brain, and if it closes, it will stop the pain impulses from going to the brain. Now, at the gate, there are factors like anxiety, depression, inactivity, etc., that are actually facilitating the gate to open. So they can experience more pain. Okay. So definitely it can. I've seen people who, if you don't address the emotional concerns, they feel a lot of pain. And that is not physical pain. They feel pain, but it is not the physical aspect of it. So you need to have what is called, very aptly put by Dame Cicely Saunders, is total pain management. I don't know if any of you have read the account of Cicely Saunders, which she had first put up when she started this total pain management. The lady had cancer. She was in the hospice. She has got a young son and a husband who's working. She said, all of me is wrong. She was talking about the physical, emotional, psychological, and social aspects of it. So we need
yes, madam. Even the latest 2020 WHO guideline also has added 6 more points to the pain definition, in which expression of pain, social, biosocial, psychological elements have all been added. So that is why this total pain is so important. And once you sort the financial or psychological issue, his pain will definitely come down.
This is available on the net also. Just look up Dame Cicely Saunders and you will find it is in the, I think, Nursing Times or something. If you Google it, you will find that account of that lady, you know, that young lady who was having cancer, lying in a hospice, and what she told I think to this Madam Saunders only, she said that all of me is wrong. There's something wrong with all of me. And that is because of her concerns about the social and if my husband doesn't work, we won't have money food to eat. So that you'll find it on the net. You can just go to. In fact, in my next presentation on difficult pain, I have taken a case scenario in which I have analyzed the various psychosocial aspects. So if you can wait for my next talk.
Exactly. That is what with pain, no, we have got 3 sessions. So that's why we have had an introduction, and then we have we saw first what is the first stage, and then we have we have different elements so that we go in a, like the WHO ladder, we are also going stepwise so that we deal with each one appropriately.
Hemaja had mentioned one nice point of LOC. Hemaja, what was that you said? Can you just tell me LOC? The various, can you go up down the presentation? In the thing, you know, the psychosocial aspects. Loss of control. Okay. What do you mean by loss of control?
He was actually, his mental status was unstable, ma'am. He used to have that mood changes, like he used to be angry once sometime, then he used to shout at the people, especially on the wife family. He used to cry. There is a loss of control on his behavior.
So all that is anger, but
Anger issues.
that is important is locus of control. What is locus of control? Feels that he cannot control his life anymore. It's gone beyond his control. Right now, he's helpless. He can't work. He can't look after his family. And he was doing all that earlier. Now that locus of control has changed. Somebody else has taken over it. Maybe his father, he's a young man, he's only 24. Probably his father, mother, or someone is now taking care. That's called locus of control. That's another thing that is there among in the emotional aspects of pain, that the locus of control has changed. He's no longer able to control his life. He has a sense of helplessness and hopelessness and powerlessness. Okay.
Yes.
That's a gate control theory of pain is what you can look up. Okay. Or if you want to read my book, I've explained that in my book also. The gate control theory.
I've just typed in the that Melzack gate control theory. That is what it is.
Melzack and Ball.
Yes. And there is a single slide which I've done for one of my presentation. If you want, I can share that. And Sri Priya will be able to. Already Sri Priya has that. I will ask her to share that slide, which will show, as Madam said, no, when everything is in one line, what is how the pain is activated, and when it is blocked, what happens. So when the gate opens and when the gate closes. In 1965, the Melzack theory was published, and that is what it is. As Madam said, if you just type Melzack gate control theory, you get it with pictures. What exactly is open
as
and closed.
As a bonus, I have myself drawn a diagram of this, which I can share it in my next presentation. Okay.
Very good. Same. Thank you, Madam. That's what it is. A very important thing in whenever pain is dealt as a topic. That is how when you rub when someone falls, and why do you get pain relief? Yeah. That is a common thing. That is the basis for TENS. So this will go on into our next discussion. I don't want to spoil our next thing. So
No, you're telling it very well, you know. Even if a child, a baby,
correct.
gets hurt, and the
Mm.
mother, I can see Hemaja with her baby. Okay. So if the baby gets hurt and the mother takes the baby, the cry will automatically stop.
Correct.
It is again a gate control theory.
That's
All
what. So that
pathway is being closed because the mother
Correct.
has just taken the baby in her hand.
So that's an important basis for so many aspects of pain management. So that theory has been of great importance and things. So
Was in 1916, okay? 50 years down the line, even now, we still believe that that theory holds good. It has not outdated also. Any other questions? But I was just feeling very sad about this particular patient that at 24 years old, and he has done so many things that are so wrong, and now he is bearing the consequences. I mean, it's really sad. He's so young, and obviously at this stage, he needs the support of his own parents at this stage, because his wife also must be much younger to him. What can she do? So I was just thinking how much prevention has a role to play rather than the treatment. So prevention by education, tobacco chewing,
Awareness.
it's so important. Then he would not have landed in that situation.
Correct.
Any other insights or queries or points which we can take in before we sign off for the day?
does anybody have anything else to say? I'll just check the chat, Sri Priya.
There's one question.
The opioid, madam will take it in the next topic.
Yeah.
Right.
The opioid is by step 3 drugs will be done in the next person. I won't be doing that, but
Okay. That's all. So as we mentioned, no, we have got for pain alone, we have got few sessions. So we will deal with each. That is why I keep telling again and again, sorry, none of you to get upset or anything like that. Everyone wants to know about everything. I do agree your burning desire to know, but we will deal with each one appropriately, because each topic will cover its own extent of subject material, which has to be covered. So we have done 1 and 2 only today. We will have the step 3 again, and we'll have difficult pain, everything. We have few sessions. So if there's something more in the chat, let me have a look.
They want to know when it will be updated. That Sri Priya will be able to help.
Yes, exactly. Sri Priya.
2 sessions have already been uploaded. This session will be uploaded soon.
And all material, all the presentation, everything is going to be there. So it should be available for all of you. And as we have said, with the gate theory and things, whatever additional information we can provide, we will give you. If you have any queries, get in touch with me or Sri Priya, and we will be able to help all of you. End of the day, we all want you to get the best. That is the aim and goal. Yes, Sri Priya, I think that with that, we have there's nothing else left in the chat box which is unanswered.
Thank you, Dr. Mary Abraham, for joining us towards the end of the day. After
will thank Madam. Madam, it has been really a pleasure to have you with us today, and such an interactive discussion we had. And that is what is more important, the knowledge element and the interactive discussion, because we have to understand what we have learned today and take it with us to treat the patients in the whole of our future. So a big thank you, Madam, for your presentation and for your lively interactive discussion too. Thank you once again. And thank you one and all too.
Thank you. Thank you everyone for joining us, and thank you, Mary Ma'am. And we do look forward to have many more wonderful sessions with you for many future cohorts. Thank you so much. And thank you everyone for making the interactions lively. And with that positive note, this is Sri Priya along with Dr. Mary Abraham and Dr. Radha Venkatesan signing off from the Tips Eco Hub. See you in the next session with another interesting topic and another eminent faculty. Till then, everyone, take care. Bye-bye.